Okay, thank you very much. I introduce myself. I'm Matthias Stuber. I'm going to talk about the works in coronary MRI. I've been asked to cover quite some territory, and I will hold myself to the same standards as the other speaker and start the timer right here. All right. So these are my disclosures. There is off-label use of GAD, and my opinion is intrinsically biased because I love MRI. So there we are. So this is a sketch drawn by Peter Libby a couple of years ago, which shows the progression of coronary atherosclerosis from left to right. It starts with endothelial dysfunction, continues with positive arterial remodeling and some plaque buildup here, and then it continues to thrombus formation and blockage of the vessels. Now, how do we address that in terms of pulse sequences that we can use to look at these different stages of atherosclerosis? Well, first of all, you have to think of a pulse sequence as just simple building blocks, and these building blocks have certain capabilities or certain tasks. These tasks are, for instance, to generate contrast, to suppress motion, or also to acquire, finally, the image data. And then these building blocks have a certain temporal relationship to each other, which can be important. So these are these building blocks. So typically what you have, it's EKG triggered. Then you have first some module that is responsible for generating the contrast. Then you have some navigator if you want to do respiratory motion suppression during free breathing, or alternatively you can use breath holds. And then finally you have the image acquisition. And as you can see, there is a very strict temporal relationship among those, and perhaps also to the R wave of the EKG. So let me first focus on how do we generate contrast. Now this is a table here. On the left-hand side you have all the tissues that are of interest to us, and here you have the different physical units, T1, T2, and frequency offsets and flow that we can exploit to generate these contrasts in the image. And it so happens that there is a relatively large difference in T2 between the myocardium and the blood pool, which we can exploit. How can we do that? Well, Graham Wright and Gene Britton many years ago at Stanford came up with this great idea to flip the magnetization into the transverse plane, let it evolve, where you can see that the magnetization of the myocardium, which is shorter, decays much more than that of the blood, which is longer. And if you tip this situation back up into the longitudinal direction, you have now more magnetization from the blood and from the muscle. And if you image this situation, in theory, you should obtain a contrast. This slide was given to me by Ruud van Heeswijk, who did exactly that. Here you can see such a T2 prep, where you can nicely see a contrast between the blood pool and the myocardium, which has a shorter T2. And you can also vary these T2 times if you're interested in that. You see without a T2 prep, you have hardly any contrast in the image, and with increasing TE of that T2 prep, you can increase the contrast. All right, let's move on to the next building block. That's the navigator. How does this work? Typically, this is like a small image that's acquired at the lung liver interface, where you can see this lung liver interface moving as a function of time. Then you can set a threshold or a window in which the data are accepted for reconstruction. If a data point falls outside of that green window, the related data are rejected and do not contribute to the final image. The disadvantage of this is the scan percentage. The acceptance rate is anywhere between 20% and 50%, which also makes the scan time a little bit unpredictable. A few words about the imaging part of the sequence. So as we go to higher and higher field strength, BSSFP sequences disappear increasingly, and the old-fashioned but very robust and stable gradient echo sequences are becoming more important, and especially at 3T, and especially Debbie Ali has done a lot of work here. Gadolinium is probably the way to go in combination with gradient echo sequences. What kind of images can you get? This is a 1.5T example, which was published a couple of years ago in Radiology with these types of sequence elements. You can see here the lesion in the proximal LAD, which is nicely also shown here in the 3D rendering and confirmed on the gold standard, the X-ray coronary angiogram. Let me see how I am in time. Okay. So these are some results from single-center trials done at 1.5T. What you can see, the sensitivity is around 80, perhaps a little bit higher. Specificity is in the 90s. These are the kind of results that we have obtained over the last couple of years. Then if you compare it to CT, this is a study that was done in Berlin by Dr. Hamdan. He compared the 3T gradient echo technique versus a 64-slice CT, which is probably no longer the state of the art. Again, sensitivity and specificity is fairly close to one another, where he didn't find any statistical significance actually between CT and MR, but perhaps that also pertains to the selection of the patients, which I'm showing in this slide here. This is actually a study which was done here by authors who are sitting here in the room even. They selected patients with a calcium score greater than 100, and clearly what you can see here, sensitivity and specificity versus the X-ray angiogram was clearly inferior for the multi-detector CT because of the presence of these calcifications. And again, MR is 80, close to 80 for both sensitivity and specificity, which is not all that great. However, more recently, these are data which were generated by Debbie Ali and his colleagues, 10 centers, I believe, in China. I'm not sure I can read it here. However, the sensitivity and specificity in that trial with more than 200 patients, 242 patients successfully completed these studies, is 91 and 80, which seems to be quite good, considering that we all know that the numbers typically go down in multi-center trials. Let's move to the next topic, the wall. And what's important to understand here, that there is an early onset of atherosclerosis, which is actually X-ray angiographically invisible, because there is an outwards remodeling of the vessel wall that has no impact whatsoever on the lumen of the vessel. Now, this is quite difficult actually to visualize the vessel wall, because the dimensions are rather small, and you somehow have to get contrast between the lumen and the vessel wall itself. How can you do that? So if you look at the T2 prep image of this right coronary artery, for instance, and I zoom this up for you, it's very hard to say where does the lumen end and where does the vessel wall actually begin. So, but again, if you go back to that Swiss chocolate here, then you can see that the T1 values can be actually exploited together with flow. And we just had a presentation of Bob Edelman earlier today, who actually first published this dual inversion concept. What happens here, you invert the magnetization of both the blood pool and the vessel wall here with a non-selective inversion, and then you have a selective re-inversion in that green slice here, so the magnetization is tipped back up. And then you just wait, go drink a coffee, come back a few milliseconds later, and just wait until this blood moves into the imaging plane, and that's where you perform imaging, at this nulling point where the blood pool that flows into the plane crosses zero. So you can go back to this pulse sequence, you just exchange this contrast generation pre-pulse by a dual inversion, and this is the types of images you can get here. Very nice dark lumen, while you see the vessel wall, which is thickened. This is a study from Young Kim and René Botnar, where they actually showed in patients with different degrees of diabetes, with and without nephropathy, that they indeed could measure a significant difference in vessel wall thickness in those patients with nephropathy using that particular dual inversion technique in combination with navigators. Now, the next question is, of course, could we also visualize plaque features? And we have seen this this morning, actually. A few speakers were talking about this, how to visualize such plaque features. So if we're going into that again, then we can see that, for instance, if there are fatty components in the plaque, then you may expect a T1 that is shorter. Also, if you think about iron, heme iron that might be in the vessel wall, then you also have a shorter T1, which you might be able to highlight, to visualize. How do you do that? Well, again, you use an inversion recovery type of sequence. So you can see here, now this is timed for the myocardium to have a null point at this point in time here, where you would perform imaging. And if you perform imaging at this point, you can see you have more signal from the plaque components than you would expect from the myocardium, and therefore you expect a high contrast or a high signal of these plaque hemorrhages or of these lipids that are in the plaque. How does this look like as far as the sequence goes? Again, very simple. You just replace the pulses I just showed before with an inversion recovery pre-pulse and a certain inversion delay of about 300 to 400 milliseconds to null the myocardium if there is no contrast on board. And this is a very elegant study that was done by a Japanese group. Quite recently, they had more than 500 patients, and they were actually looking at the event rate in patients who had enhancement like this. They call it PMR. This is kind of a calculation with some fudge factors in there, but nevertheless, if you look at this plaque here that is enhancing, so this would have a higher PMR value. So when they were looking at the event rates, it was very clear that more events happened in those patients who showed these plaque features and had coronary artery disease defined by X-ray angiography. What's interesting here is if you look at these green patients, for instance, these are also patients who had an enhancement in the plaque, but which did not have X-ray defined coronary artery disease. And yet, there was a significantly greater event rate in those patients who showed these features. Debbie Ali and his group took this to the next level and actually combined this technology in a very elegant way, where you get an anatomical image and an enhanced image with inversion recovery at the same time. And then you can fuse these images to localize where the enhancement is coming from. And what makes this study very particular, they also compared it to an invasive gold standard, to OCT, where you can see here in this region a lipid pool and probably also intraplaque hemorrhage. They also calculated this local signal enhancement and related this to the OCT score. They did that with contrast agent and without contrast agent. And you can see here you get a rather good correlation between what you find on OCT and the enhancement they measured by MRI. Okay, that brings me to the last step, and I will see how much time I can give myself. 3 minutes, all right. This is endothelial dysfunction. So what's important to know is that the endothelium releases actually nitric oxide, and this nitric oxide is responsible to maintain the vasomotor tone. So in case of stress, for instance, that you can deliver more blood flow to the myocardium. Now, if the endothelium is impaired, there is no or impaired release of nitric oxide, and the vessel can no longer accommodate a change. So that's a result of this endothelial dysfunction. This has been shown to be related to later events on the one hand, and on the other hand, this has mostly been done with X-ray angiography and injection of acetylcholine, so quite an invasive technique which cannot be done in healthy volunteers, for instance. So what happens with the endothelium if the function is normal and you provide stress, then the diameter of the vessels go up and the flow goes up. In abnormal endothelial function in patients, there is a failure for the diameter to change, and there is a failure for the flow to increase or for the velocity of the flow to increase. And this is measured as vasomotor response in change in response to an endothelial dependent stressor, which can be a hand grip, for instance. Alison Hayes and her group did that at Johns Hopkins, where you can see here a healthy volunteer at rest and during stress. You can see how the flow is increasing in that vessel on the one hand, and the diameter is also increasing in response to this hand grip stress, whereas in the patient with coronary artery disease, this does not happen. If you look at this statistically, then you clearly see in the healthy cohort there is a clear vasodilation of the coronary arteries in response to hand grip, and the velocity and the flow the same, whereas there is an absence of these parameters to increase in the case of the patients. And what she did, which is very interesting, she also related these measurements of wall thickness to the area change in response to the hand grip. So two very early manifestations of atherosclerosis, endothelial function and positive arterial remodeling. And she found actually quite a remarkable correlation among these two factors, suggesting that there is a relationship between endothelial dysfunction and early progression and of coronary artery disease. So that brings me to the summary. In well-trained hands, coronary MRA performs almost like CTA. but sequences tailored to highlight soft tissue characteristics clearly enable the visualization of very different features, including the lumen, the wall, plaques, flow, and also coronary function. So quite an impressive array of things we can do with MRI. And early indices of atherosclerosis can be assessed non-invasively, safely, quantitatively, and repeatedly. Thank you very much for your interest.